Hello everyone, today I will speak about Guillain-barrè syndrome. It is actually a neurological disorder that person's immune system will attack the healthy nerve cell inside the body. If we look at this girl we had, she says, I can't move my legs. If we take a history from her, she would say, most likely, that she had 2 weeks earlier a respiratory infection. That respiratory infection starts with cough, sometimes sputum with a chest pain, and after 2 weeks it resolved, but suddenly she had weakness that beginning in her toes and fingertip of her hand, and it starts distally from that and becoming proximally until involving the both arms and both legs, and she don't know why. The whole history of her was in only 3 weeks, meaning 2 weeks of respiratory infection and 1 week since she developed the body symptom. That most likely would suggest Guillain-barrè syndrome other than any disease, because it is mostly fast. Other neurological disorder would take months, even years to develop, but that took only week. If we explain what's happening, actually that respiratory infection that she had is activate her autoantibody. The autoantibody will damaging that viruses she had earlier. The antibody want to clean the body from viruses, want to clean the body from infections. But that infection actually having an antigen that resemble or it found actually on a nerve cell. So same antigen was on nerve cell. This antibody will stop recognize which one is for a healthy nerve cell and which one for the infection. So it will continue its attacking and it will reach the nerve cell and result in damaging it. That infection, if we talk about, is most likely either cytomegalovirus or human herpes virus, sometimes which is even more likely to be, which is Campylobacter jejuni, that written in most resources, and it's mostly in the area of North America. Okay, now if we talk about the Guillain-barrè syndrome, it's actually having a 4 types. The most common one would be the inflammatory demyelinating polyradiculoneuropathy. That type meaning the antigen that the nerve cell had is the same antigen inside the myelin, inside the myelin. It is the same or resemble antigen in the virus or bacterial infection that she had 2 weeks earlier. So the antibody will damage this myelin sheath. It will attach to the myelin and result in damaging complex. That's the most common type, which called an inflammatory demyelinating polyradiculoneuropathy. The other types would be on the axon, which is acute motor axonal neuropathy and acute motor sensory neuropathy. Whereas the antigen that is found on the axon is resemble the infectious antigen. So the antibody will leave the myelin and go toward the axon, but it's actually not common as the myelin. And we have the fourth type, which is called a Miller-Fisher syndrome. In a Miller-Fisher syndrome, it's actually different than the three other types, whereas we had a rapidly evolving ataxia, and also we had areflexia of the limb that we found also on the other these type that we talked earlier. And here we found ophthalmoplegia and sometimes even pupillary paralysis. Okay, if we talk about the diagnosis, the history and physical exam, that the history as we talked earlier in the story, and the physical exam, the doctor or clinician will found there is no ankle reflexes in that patient, and the symmetrically developing progression in the patient will lead him more likely to think about Guillain-Barrè syndrome, and it's more likely there is no sensory problem. And for investigation, the cerebrospinal fluid analysis will give us elevation in the protein while no elevation in the cell. That is about 1 to 10 gram per liter protein, and there is no elevation in cells. It's called actually protein cell dissociation. And even if present, it is actually not for a full time, because it is if present for a full time, we will think about other diagnosis. For this disorder or for this syndrome, we actually are afraid about the respiratory complication, because pharynx nerve could be also involved, and if pharynx nerve involved, there will be a diaphragm paralysis that result in respiratory failure. So 30% of patients will need mechanical ventilation if the vital capacity less than 15. And after 2 weeks, it could need intubation. For treatment, we have a supportive care. We could monitor the respiratory function, and even the autonomic nerve could be also involved, result in postural hypotension, result in higher heart rate variability. So we should also concern about that. The patient could stay for more than 2 weeks in a bed until he starts kind of resolving. So even that could lead to deep vein thrombosis, so we should give him a thrombosis prophylaxis. For specific treatment, that should we give him as rapid as possible and should not wait the cerebrospinal fluid analysis. It is actually an IV immunoglobulin that given 5 daily infusion for a total dose of 2 grams per kg. For 5 days, the total dose will be 2 grams per kg. And we could change that for the same effect and use the plasmapheresis. But as we said, as rapid as possible, because if we had 2 weeks without treatment, we could not know is that these available treatment is effective or not till now. But as long as the patient suggesting that will have more progression, this treatment should be given. And when patient diagnoses it as early, we should give him the treatment as early as possible. That's all. Thank you.